My name is James Ryan, and I'm an MD, and I work here mainly specializing in adult psychiatry. I do work with 12 and above, but mostly with adults. And my position has somewhat changed over the last year as I've focused more on the advanced psychiatric treatments, as we call them. So working with things like transcranial magnetic stimulation, as well as theta burst stimulation, and then ketamine, and then we have other types of direct current stimulators and things that we use as well.
When did you first start using TMS as a treatment option for your patients?
Well, TMS is something that I was first introduced to in my residency. I know they've done a lot of research at UCSD, but mainly here at Redemption from the get-go. And so that was something that Dr. Friday had already had going here for patients. And of course, TMS has been around since 1985, something that's been very, very effective for patients, especially with chronic depression. And so that's something that's been very, very effective for patients that I've referred.
You had mentioned that you had had a lot of success with treating some patients for tinnitus or tinnitus. What areas did you target of the brain? Did you target? Why? And what were the results that you had?
So the first area that we focused on was an area called the temporal parietal cortex, associated with the auditory cortex. And so that's basically a position. If you look here at the tragus of the ear and run up to about a 45-degree angle, you can kind of pinpoint that location. And so for most patients, they'll respond very well. So if you treat here, say on the left, that will treat the right ear, and then vice versa. And so for patients, I would say the vast majority with tinnitus have responded very well to that location. I had a few patients that were more resistant, and so I started to do a lot more research and discovered something called the default mode network of the brain. And that's an area that's located here towards the back, called the precuneus, and it's right above the occipital lobe. And so that's something that they've done a lot of research recently. There's a lot of ongoing research about this default mode network. And so what I discovered for patients with tinnitus is their brain has an inability to be at rest when they're at rest. So in other words, there's two networks in the brain that can be active. So the first is the dorsal attention network, and that's most of these frontal lobe regions that we typically treat. And then when someone's at rest, so if they're just daydreaming or they're in like an introspective type of a state, then the brain will be at rest. That's when the default mode network kicks in, and most of that is here in the precuneus region. And so for a couple of patients that did not respond well to the typical location, I attempted to use a continuous theta burst stimulation bilaterally, and that was very effective for several of my patients that were initially not responsive.
What other conditions have you used TMS to successfully treat other than depression? You had mentioned, what was it?
Trigeminal neuralgia.
Yeah, trigeminal neuralgia. That's it. That's the
yes.
one.
So
Talk to us about what tell us what trigeminal neuralgia is first, and then tell us how TMS can help treat it and how.
Sure. So here's something that I've noticed is that a lot of times in medicine, we tend to focus in on the symptoms associated with our specialty. And so what I've noticed over time is that if I go in, for example, and give an FDA-approved 19-minute depression treatment here on the left, the patient will do well, they'll respond very well. However, they often have anxiety components or a pain component, and those symptoms, if left untreated, then will bring back the depression over time. And so I've started to look more at patients as a whole and looking at every factor that can affect mood and sleep. And so a lot of patients of mine have had a significant anxiety component, whether it was a generalized anxiety disorder or even a post-traumatic stress disorder, PTSD. And so done a lot of work with the theta burst protocols that Cloud TMS has. And so most of those treatments take place here on the right, dorsolateral prefrontal cortex. However, I've also discovered a lot of different areas for treatment for pain as well. To answer your question about trigeminal neuralgia, I had a patient that had a couple of pain syndromes, so depression, anxiety, bilateral tinnitus, as well as trigeminal neuralgia, and then which the pain region was located here, completely covering the entire head on the right side, including the ear. And then it also developed a TMJ pain syndrome. And so to target the trigeminal neuralgia, I looked at a lot of the circuits of the brain and the region. And the first place that I paid attention to was just the motor cortex. A lot of pain syndromes will respond well to treatment with intermittent theta burst in the motor cortex. And so I looked at regular homunculus of the brain, and you can take a look at the motor cortex and you'll see that a lot of the facial structures are located here in the motor cortex. So, this would be this region here. And so initially I tried a few approaches, different coil angles, and what I found in the end was that to treat her tinnitus as well as the pain, both the trigeminal neuralgia and also the TMJ pain syndrome, I treated here, and then I also moved up along the plane to treat also a little bit higher, about an inch higher, to treat the rest of the pain, because at first we had missed portions, like she had most of it completed but then missed this region of the face, and then later it was this back region here. So eventually I discovered using the coil angle, so I placed the coil angle approximately this way. It was straight up and down at a 0-degree angle, and then she responded exceptionally well, and by doing so that also improved the TMJ pain and the tinnitus. And so I found that there's a positive feedback loop between, or a snowball effect as I often call it with patients, between their pain syndromes and their anxiety. So worsening pain causes worsening anxiety then triggers worsening pain. It just becomes this positive feedback loop. And so by treating both anxiety as well as, for her, the pain syndromes here and here, then she responded, had a much better response, and had, even with the treatments, because she's still receiving treatments, actually got up to 95% improvement, which is absolutely incredible for that type of a pain syndrome. And she had previously had very intrusive type of surgery, invasive surgery I should say, with a gamma knife procedure, and was getting ready to do another. And so had very, very great results.
What protocol did you use for the trigeminal nerve, for the stimulation along the motor cortex?
So what I looked at is primarily the intermittent theta burst protocols. And so this would be one that would typically run for about 6.5 minutes. And so I focused on having the coil. I tried different coil angles, and what I found is when you align with the tract of the motor cortex, that gave the best result. And so I aligned the coil and then treated low and just a little bit higher, that way I can cover all of the facial areas that were affected with her pain syndrome, and ran each one for 6.5 minutes. And then I also found that it was much improved to just do a general treatment here at the top of the head with M1, and the combination of that completely resolved all of her pain issues.